I'm a president of National Cancer Center of Korea. It's my great honor to chair this important session. Digital transformation in hospital has been an emerging issue, but it's also a never-ending story. Korea is well known for having one of the best IT infrastructure in the world. Korean hospitals have attempted many transformations even before the COVID-19 crisis. The COVID-19 pandemic has brought these efforts to the surface and accelerated the speed. In this special session, the presenters will share their experience and the insights of the transformational evolution of Korean hospitals in the year of COVID-19 and after. Let's begin our session. Let me introduce our first speaker, Wang Jun Lee. Dr. Lee is one of the most influential persons in the Korean healthcare sector. He is the chairman and the CEO of Myeongji Medical Foundation, including 2 acute hospitals and 3 long-term care facilities. He is also a CEO and the chairman of very venturous biotech companies. As an executive chairman of the International Affairs of the Korean Hospital Association, he is a general secretary of the Korean Healthcare Congress. His topic is flexibility and the transformation capacity of hospitals in the age of COVID-19. Dr. Lee, please.
Greetings all. My name is Wang Jun Lee. I'm currently serving as General Secretary of Korean Hospital Association, COVID-19 Emergency Response Committee, and the chairman of Myeongji Medical Foundation in Korea. As COVID-19 pandemic has prolonged, it has been our key concern to operate the healthcare system in a seamless manner under this pandemic. Today, I would like to talk to you about flexibility and transformation in hospitals with examples of urgent response in the COVID-19 pandemic. There are 5 bullet points. I'm going to introduce Myeongji Hospital and the current situation in Korea in terms of the COVID-19 pandemic. And I will explain how the existing resources were utilized with flexibility, how the organization was structured accordingly, and most importantly, how the healthcare delivery system was transformed due to the pandemic. Firstly, I would like to introduce Myeongji Hospital under the Myeongji Medical Foundation. We are a general hospital with about 700 beds and visited by 1.3 million patients annually. It is located about 40 minutes away from the center of Seoul, the capital city in Korea. We have another general hospitals in Jecheon and Incheon in Korea, and 2 nursing homes, 1 long-term care hospital under the foundation. So we are not just providing acute care for patients, but also providing life cycle healthcare services for all patients. Myeongji Hospital has played a critical role with patient safety as its priority during the major pandemics. I have seen and experienced 3 types of new viruses while managing Myeongji Hospital since 2009. Following my inauguration in 2009, I faced the spread of swine flu firstly. Even though we were not fully prepared to handle such an epidemic, I can proudly say that we responded extremely well. Since then, we have been regularly conducting training and drills in response to new infectious diseases. And with this constant effort, we are better prepared and improved each time in response to the outbreak, including MERS and COVID-19. As a result, Myeongji Hospital was recognized for the Beyond the Call for Duty for COVID-19 recognition program by IHF last year. And the paper written on a first case of COVID-19 in Korea was selected as the most cited paper in the past 10 years on Journal of Korean Medical Science. In my opinion, the great efforts by hidden medical institutions like our hospital made world-famous Korea's quarantine. Now, I would like to present briefly Korea's current COVID-19 situation. The first confirmed case of COVID-19 in Korea was reported on January 20th last year. And as of October 25th this year, Korea is recording a total of 3,000 confirmed cases with the mortality rate of 0.79%. This chart shows the overall epidemiological curve in Korea. Since last August, the number of daily confirmed cases has exceeded to 1,000 cases, and the fourth wave of the outbreak is still ongoing. Most of them occurred in the Seoul metropolitan area. So we have been very carefully dealing with the situation and facilitating the vaccination plan. Fortunately, the mortality rate has been meaningfully decreased since the vaccination started from this February. So far, almost 80% of Koreans has been vaccinated for first doses, and more than 70% of Koreans has completed the second doses of vaccination. Although hospitals provide healthcare services as products, the management is also somewhat similar to a manufacturing industry. The initial investment required is similar to that the semiconductor industry. Once the buildings are constructed and the medical devices are installed, it is very difficult to make changes afterwards. Also, as you may well aware of it, it takes a significant period of time to train the medical personnel for providing a good quality of healthcare services, as these are literally professionals and experts in the field. The unexpected COVID-19 pandemic brought an opportunity for hospitals to consider various issues regarding existing resources, personnel, and most critically, the healthcare service delivery system. Now, I would like to talk about how drastic changes were made for survival, along with the anecdotes from the front line. First of all, we have utilized and relocated facilities with flexibility. We developed dual-track healthcare system and eased into our hospital. Dual-track healthcare system is a strategy to maintain the core functions of an acute care hospital while simultaneously treating a dual population of COVID-19 and non-COVID-19 patients by appropriately allocating medical resources. In other words, the purpose of the system is not about response to infectious disease surge, but rather about how to provide the essential medical services for both non-infected and infected patients simultaneously. The key is separating spaces into COVID-19 zone and non-COVID-19 zone completely. On the right, you can see the photo of Myeongji Hospital and the building E also named as Echo Ward. All COVID-19 related patients are currently being treated in the Echo Ward, while other existing outpatients are treated other buildings. All personnel, including the medical staff, are also separately allocated into two buildings for safety. This isolation of physical space and personnel has reduced the anxiety among visiting patients as well as hospital employees, and it was very effective in complying with the quarantine measures. This dual-track healthcare system at Myeongji Hospital was recognized by the international academic community. And the Journal of the Hospital Infection has published a research paper under the title Providing Essential Clinical Care for Non-COVID-19 Patients in Seoul Metropolitan Acute Care Hospital Administered Ongoing Treatment of COVID-19 Patients. As you can see, the left image on the screen, we flexibly opened or closed each ward along with the patient surge or medical staff's availability time to time. Myeongji Hospital has been operating 13 negative pressure isolation beds since 2013, nationally designated infectious disease hospital, even before the MERS outbreak. But nowadays, we expanded to 26 beds for all ICU isolation beds. The ward is completely separated from the general ward, and it is designated to completely isolate the movement of human traffic as well as the ventilation and air conditioning facilities from those of the main building. The structure of the negative pressure isolation ward is designed to be eligible for changing in response to disaster situation. As shown in the diagram, the doors that are used in normal situations are designed to be closed to completely seal off the space in case of a disaster. This is an example of a flexible utilization and transformation of a space in preparation of different scenarios since the initial stage of design. I think this is very important, especially given the time and financial costs associated with immediate response to unexpected patient cases. In Korea, among COVID-19 patients, those who present mild symptoms are treated at so-called the community treatment centers. As the numbers of hospital beds are limited, not all patients need to be hospitalized. Therefore, the level of severity was classified and the on-site medical staff were dispatched in connection to the hospital system for treatment 24 hours and 7 days. The advantage is that although it is a physically different location, the same medical services are provided, and this is a very effective way of responding to severe cases that may occur unexpectedly. In addition, utilizing neighboring facilities is a good idea to overcome limited hospital resources, especially hospital beds and services provided. We also set up dedicated facilities outside of the hospital to thoroughly control the access to main building. Treatment and testing can be provided in any time in the facility when suspicious symptoms are found. The primary purpose of the facility is to prevent further spread of infection by completely spreading the area from other treatment buildings. As other medical services, quick decision-making is critical for highly contagious disease of COVID-19. Many cases required real-time collaboration with other departments. At Myeongji Hospital, we called an emergency response meeting immediately after the first confirmed case was reported in Korea, followed by regular meetings for follow-up. And above all, we created a discussion channel through SNS so that not just management decisions, but also clinical decisions could be made in a timely, efficient. During the MERS outbreak, we have seen a surge of confirmed cases as a result of the failure to share accurate information even within hospitals. Inaccurate information and fake news with unverified source create anxiety and fear among people. In this time, all information related to COVID-19 pandemic was shared with internal and external staff, and I believe it has enabled us to respond more quickly. A sudden surge in the number of confirmed patients required increasing the number of medical staff. However, as I mentioned before, training professionals takes a long time, especially in the case of medical professionals who provide critical care in completely isolated environment. In preparation for this, Myeongji Hospital conducted a customized training for the nurses at the existing normal wards how to give care for COVID-19 patients. We ensured that 25% of the whole nurses was ready for on-call duties in case of emergency and completed training with a manual, including on-site training. Responding to crisis is difficult without continuous training. At Myeongji Hospital, we annually hold all staff training for responding to crisis with different scenarios since 2014. I believe these processes have contributed to our ability to respond to the COVID-19 outbreak. With the increasing number of patients, staff's stress has also increased. The hospital created a resilience program in addition to the financial reward. We provided psychological counseling for stress relief and hosted events through internal workshops, which the staff gave very positive feedback. We focused on the flexible utilization of resources and manpower, but there was a change in the delivery of services, which are considered the essence of a hospital's function. The numbers of patients that actually visit hospitals are decreased, but the patients' demands for hospitals are increased. So we established a platform called MJ Virtual for the patients to access the healthcare services. It allowed patients to use the treatment service regardless of time and location, and our existing patients could receive the desired information when they want. In order to utilize these platforms, using ICT machines is essential. For the first time in Korea, we signed an MOU with InTouch Health in the US to provide interdisciplinary treatment using smart robots. Telemedicine has been boosted due to COVID-19 for especially elderly patients who are vulnerable to COVID-19 infection and confirmed patients who need to receive treatment without contact. COVID-19 brought an opportunity for building a new system in the operating rooms. Unlike other surgeries, operating on patients with COVID-19 requires about 3 to 4 times of the time and human resources. To efficiently utilize these, we built operating rooms with negative and positive dual pressure system. We are realizing that the transformation in medical services has been accelerated in response to COVID-19 using ICT technology, including the control system with face recognition. In the near future, I believe that the hospitals will go to the patients rather than the patients visit the hospitals. If we visit Korea, you will meet the testing center of Myeongji Hospital at the airport, since it is essential to control COVID-19 for the people both entering and leaving Korea. So far, I've introduced the present, and now I would like to talk about the future. This is the Myeongji Hanam H2 project, which is scheduled to start in 2023. Future hospitals will be built with advanced infrastructure to prepare for another pandemic with completely different type, and also to provide people-centered full cycle services. The newly built 800 beds Hanam Myeongji H2 hospital will implement a total life care that encompasses acute, subacute, chronic stages at a variety of specialized centers. I believe you will see futuristic, innovative services at Hanam Myeongji Hospital, which will be stood as a biomedical cluster based on optimal design to prevent the spread of the infectious diseases. I have talked about how we are coping in the presence of COVID-19 that no one could have predicted, and also the plans for the future. There are 3 reasons that allowed us to have such competitive edge. 1, clear goals with long-term strategy. 2, the leadership that could implement this and the financial ability to execute. 3, it is most important, rapid communication and collaboration between internal and external parties. Also, I would like to emphasize global cooperation particularly. I believe this Congress is also one of the cooperative efforts to overcome COVID-19. I hope my presentation has been helpful to you in setting directions for the future. Thank you so much.
Thank you, Dr. Lee, for sharing your important experiences. And your story was very touching. And we now move on to the next speaker. Next speaker is Gun-ho Na. Dr. Gun-ho Na received his Korean medical degree in 1992 and the PhD in 1999 at the Yonsei University. He successfully completed his urology residency at the Severance Hospital in year 2000. At present, he is a director at the Naval Healthcare Lab. Prior to his appointment, he was the Chief Strategy Officer of Yonsei University Health System. His topic is Global Digital Healthcare from Perspective of IT Industry. Dr. Ra, please.
Hello, this is K.H. Ra from Korea. On behalf of Korean Health Hospital Association, it's a great honor to speak International Hospital Federation meeting in beautiful Barcelona. Today, I'll be speaking about the global digital healthcare from perspective of IT industry. I'm affiliated with the Naval Healthcare Lab and the hospital here in South Korea. So the digital healthcare in the post-COVID era, we can define four distinct keywords. First is the interoperability and the personal healthcare record, or PHR, which is a healthcare data integrity and interconnectivity. Second is the total healthcare. The healthcare is not just limited to hospitals, but it's a continuum of healthcare with the entire cycle from home, work, and when we play and when we rest. And the third is the digital medicine. And I'll show you a few examples of the new therapies which are more prevalent in all parts of the world. And the fourth one, I think, is most interesting for all of us, for the hospital associations all over the world, which is the AI technology for doctor, which will make our jobs efficient for the work environment, not just for the doctors, but nurses, physical therapists, and the administrative helpers for the workforce of the hospitals. So the interoperability and PHR. The medical record in the most countries is stored by individual hospitals. It is mandated by the government usually for X number of years, usually 5 years to 10 years. Here in South Korea, it's a mandatory recording should be kept for at least 10 years, which means that there was no connection or interchange between hospitals. Their hospitals were doing their safeguarding, storing the hospital, the medical records. So in case if the patient or the patient's family requires to have a copy, you usually had a Xerox copy, or nowadays you can make into the CD-ROMs or the thumb drives. But I think in the realistic world, to be setting, the primary care provider, secondary care provider, the tertiary providers should have all their information readily available in single connection, and it should be interchangeable. So that means is that between the patient from primary care, secondary care, or the tertiary hospitals, the information should freely flow. I think we can have a few very early examples of this models in various parts of the world. First example is the healthcare management system by country of Estonia. Estonia is renowned for their state-of-modern information system by the government, and their distinct three portions of electrical health record comprises of three parts. First is the e-health record, which collects and integrates data from all medical services across the nation for patients and doctors. And the data categories it comprises for the whole set, including diagnosis, prescriptions, vaccination, dental charts, ambulance charts, the checkup records, and I'll explain more detail about time-critical data and other notification as well. And secondly, it is used extensively for the emergency conditions for the e-ambulance, which carries the ID number of the patients in the ambulances and directly transfers to the hospital. And the third most useful data set is the e-prescription, where the prescriptions are issued and processed online. The important time-critical data is the critical information for emergency situation as your blood types, allergies, medication, and the pregnancy status. So all these informations are readily available in e-ambulances setting. So you have the continuous the access of your healthcare record by everyone who is in charge of the healthcare. Second is the Korean model. Korea in this year, earlier this year, the government opened the My Healthware Way the app, which comprises of the 4 different distinct information. First is the prescription record. Second is the hospital visit record. Third is the vaccination. And the fourth is the nationwide checkups, which are usually done every 10 years up to every 2 years. So this is the first step in providing the data in the ecosystem in the medical fields. This has been accessed by your own access files. And this is we learned this experience from consolidating all your financial data from your banks and the insurance companies. So all these previous experience by the Korean government has extended to gather all the government kept health records in 4 different parts. Now, on the second phase, starting next year, 2022 and 2023, the Korean government will extend to do a pilot studies in various primary care, secondary care hospitals, and the tertiary university hospitals to share seamlessly the healthcare information through your app on your mobile devices. Second portion I would like to speak about is the total healthcare. Treatment, the healthcare was provided usually at the hospital or the clinic settings. However, as we all know, the treatment does not comprises the entire journey of the healthcare. It should include the prevention, treatment, follow-up, and the total healthcare, which start from prediction. And it should comprises not just prevention, diagnosis, and treatment, and also it should encompass aftercare of the patients as well. So this is different from the traditional healthcare where the diagnosis and treatment is the mainstay of the healthcare. But more, all these 5 components of healthcare is the total healthcare. So I'll give you a few examples. First is the Omada Health, or there are different apps available now, such as the new map, which just raised more than $4 billion US, which comprises of a gathering healthcare records, including blood sugar, blood pressure, meals, how many steps you walked, medications and body weight, etc. Secondly is that it gives you healthcare monitoring and reports and provides weekly and monthly health record monitoring up to 30 days, 60 days to 6 months. And the third portion is a health management. I think this is the most important part where it including coaching and lesson sessions and manages, for example, diabetes through a professional one-on-one counseling or group coaching programs. And the fourth important aspect is your peer community sites, where it enables you communications among the same group of members, let's say a diabetic patients or the hypertension patients. So through your app, you can manage your health records, monitoring health reports, challengers, and your discussions by coachings and community. The second example is from Japan, where chronic disease managed such as diabetes or hypertension is same managed by cell phone, but what is unique about this model is that your compatible devices include Apple Watches, Fitbit, and Omron, the blood pressure measurement machines. And the important issue, the aspect of this program is that the coaches, your managers are actually your hospital medical staffs, including the doctors, pharmacists, your nutritionists, and more importantly, your nurses as well. So they actually visualizes your data and shares healthcare records with medical institutions. In some ways, the medical institution's admission page shows you your entire total health records into their EMR as well. So this is I think one of the most advanced models where the actual healthcare professionals that manage your health, chronic diseases, are in charge of taking care of your everyday activities as well. The third portion I would like to mention is the digital medicine. The treatment medicine usually comprises of drugs, injections, and medical devices. I am a urologist. I use robotic devices for my prostate cancer and kidney cancer patients. However, there are totally new types of therapy available for your apps, wearables, the VR and AR devices, and I like to give you a few examples. First example is the Pear Therapeutics. I had an honor to visit their world headquarters in Boston, United States, Massachusetts last month. This is a first FDA approved digital therapy in the world in two fields. One is addiction and the second is insomnia. So this is a prescription model where you are actually, digital therapeutics are prescribed by your physicians and means of your assistant with your current treatment programs. So cognitive behavioral therapy is carried out through various contexts, including text, videos, graphics, and improved symptoms and retention of current treatment by 9 weeks for the insomnia patients and 12 weeks for addiction patients. So it was first approved by the US FDA in 2017. And I think this is a great era that the first time in the world, at least in the United States, it has been reimbursed by insurance companies to control your motivations through rewards, such as badges and gift cards. And there are 6 cores for the 6 weeks program for the insomnia, which is a great healthcare issue. So you can get ready programs, sleep windows, behaviors, thoughts, educations, and look ahead, step-by-step insomnia program for 6 different cores for 6 weeks. Second program is the Kaya Health. It's not just for your mental health for using digital solutions, but this is a musculoskeletal diseases by orthopedics, rehab medication, and then the neurosurgeons as well for the pain relief. So it provides pain relief exercise content for back and buttocks and knees based on motion tracking technology of your cell phone. So it provides tailored sessions based on the survey at the first sign in and starts exercise after induction video and practice. And secondly, it is AI-based digital coach, which analyzes your moves and provides audio feedback. And all these feedback are recorded in a daily program session, which also plays an audio recording to introduce the processes and provides additional information about pain. And it reviews daily programs recommended for users. And if you've done successfully, it puts you a completed signs. And finally, it has a very delicate, the user's progress status report and exercise history, and provides obviously the reminder of your training sessions throughout the notification function. So their early report has provided improvement in not just in pain for the 33% versus 14.3% for the control group, but also in improvement in mental health and bodily functions. So I think this is an exciting technology taking care of the musculoskeletal disease. The third one is about the digital therapy for the ADH, attention deficit children. So this is a US FDA authorized digital therapy, which uses a gamification technology. So you use a game to treat ADHD patients. So it's a self-driven video game for cognitive ability improvement. So you play 25 minutes per day for 3 months, and it has shown great effectiveness in more than 600 children in 5 different clinical trial settings. Another exciting area is the Oxford VR, which uses your virtual reality programs to treat acrophobia, social phobia, and psychosis, the fear of heights. So this uses a very innovative cognitive behavioral therapy. So you don't have to go up to the roof or the land bridges to feel the acrophobia or the afraid of heights, but you can put up your headset for treatment and complete sessions such as taking escalators or making orders through the virtual coach with an instruction on the virtual reality. And of the 100 patients who are afraid of heights, 75% was shown an improvement. So I think this is a great usage of the VR, AR technology in the acrophobia or the social phobia settings. And lastly, I'd like to stress upon the AI for doctor technologies. When we look at our jobs in the hospital setting, this is an endless loop of reviewing patients, speaking to the patients, and charting, and going through this loop again and again and again, day and night, every single day. However, as a physician myself, I think it must be a better way in this age of cell phones and AI technologies. So here at Naver Healthcare Lab, we are partnered with 700 engineers and the supercomputers to provide what are the solutions can help physicians, nurses, physical therapists, and the administrators and free them from the laborious, repetitive jobs to more creative jobs that we're trained for. So there are the method as the recommending the doctor's offices, AI examinations using chatbots, voice EMR, AI identification, your face sign, or your textures. We have a technology where we call a face sign at Naver, where if you are wearing a mask, the AI still recognizes you even though you're masked and have glasses on. So your other features on your face, you can still recognize. If you're running through the gate, we still can recognize you. So this is a great technology. There are many different solutions are developed for the AI for drug developments. And I'd like to speak to you more about the EHR and remote consultation as well. So one of the most famous example is the Babylon Health, which is utilized in UK. As you know, the UK is famous for a nationalized healthcare called the NHS. And it is usually done by the primary care physicians or the general practitioners, which are very limited resources. So as in Korea, one of the technologies from UK most famous was from Google a few years back, about 5 years back in 2016 was the AlphaGo. We played Go, the ancient game of Go here in East Asia by the computer, the Google company called the DeepMind. However, the DeepMind was originally set up to tackle some of the healthcare issues, but it was more famous tackling on playing Go, which we never thought AI could beat any human professional players. But I think the same technology is now being utilized to offer the evaluation for the monitoring, health check, talk to doctors, and ask Babylon in UK. So in theory, it can collect existing medical information by chat, and it can reduce burden on various portions of the medical personnel. The more exciting technology is the nuance, which has been in existence for more than close to 20 years in the United States and various English-speaking countries. And their famous technology is called the Dragon, where it's a dictation program for usually the radiologist or primary care physicians or internist. And then recently, earlier this year, April, this company was acquired by Microsoft for the value of close to 20 billion US dollars. So the Microsoft thought their voice technology and the files are very integral for Microsoft cloud businesses. I had pleasure to use this technology last month in the United States. It recognizes each physician's voice very nicely. Now they're moving on to the next phase of the advancements called the DAX on the right side. The voice recognition AI recognizes that each portions of the top, which treatment is necessary, automatically tells the voices of the patients and doctors apart, and automatically extracts information from the treatment recording in the top documented. And more importantly, you can actually put orders into the EMR or EHR setting. So I think it's being on development in few United States hospitals. But for English-speaking countries, I think this is a very exciting technology to see. Lastly, I'd like to speak about the arteries, which is the AI platform for medical image analysis. So one of the exciting technologies is the cardio AI and lung AI and chest AI, which realizes images from 2D, making to a 3D to even 4D setting with the state-of-art web rendering technology, which actually accurately visualizes the whole flow of the heart. So it's not just the image, but it shows the actual flow. And it reduces time by 45% using the lung AI, so you can identify solitary pulmonary nodules very well as well. So neuro AI is another exciting technology where you can diagnose brain-related diseases such as brain tumors and strokes with a 95% accuracy. So I think all these technologies makes our jobs easier for everybody who works in the hospitals, not just for the physicians, but nurses, physical therapists, and the administrators as well, which will make our jobs much easier and much more fulfilling, and which will result in better patient care for all the hospitals across the board. So once again, I'd like to thank you very much for today's opportunity on behalf of the Korean Hospital Association. And I would like to see you in person in next year's meeting and wish you a great time in Barcelona who are in person this year in Spain. Thank you very much.
Thank you, Dr. Ra, for your nice presentation. You showed the prosperous future of global digital healthcare. Thank you. Let me introduce our third speaker, Wang Jun Lee. Dr. Wang Jun Lee is a professor of hospital management in the Department of Preventive Medicine and Public Health at the College of Medicine of Yonsei University. He is the president of Korean Society of Hospital Management, the largest academic society for the field of hospital management in Korea. Dr. Lee, please. His topic is Changing Role of Hospitals, Pilot Projects in Korea, Personal Health Record and Smart City. Dr. Lee, please.
Hello, I'm Sang Lee, a professor at Yonsei University in Korea. It is my honor to have the opportunity to present at this World Hospital Congress 2021. I really wanted to come to Barcelona in person, but due to COVID-19, I'm sorry that I made my presentation online. In this presentation, I'd like to introduce two pilot projects currently going on in Korea and at the same time think about the changing role of hospitals. Before we talk about main topics, I'd like to briefly introduce the Korean health system to help you understand my presentation better. Let's look at the Korean health system briefly. Korea has a national health insurance system which is run by the central government. This is a compulsory system, so all Korean people have to join. It was started in 1977 and in 1989, after 12 years of establishment, it reached universal coverage. If you look at the healthcare delivery, more than 90% of hospital beds are private. So healthcare delivery heavily relies on the private sector. One thing to mention is that there is no gatekeeper in the system. So patients can choose almost freely whether it is a primary physician, secondary care, or even tertiary hospitals. Korean National Health Insurance covers almost all Korean. As you can see in this slide, the population of Korea is about 53 million. Among these, 97% of the Korean population are enrolled in national health insurance. The remaining 3% who are low-income citizens and they cannot afford the insurance premium, so they are covered by a different social insurance system named medical aid. This slide shows the structure of the Korean health insurance system in more detail. At the above part, there is a Ministry of Health and Welfare of central government. They governs the above policy. The actual operations, such as collecting premiums and paying to the providers, are managed by National Health Insurance Service. The patients pay insurance premiums to the NHIS, and when they use medical services, they pay some out-of-pocket money. In the right side, there is another institution, which is the Health Insurance Review and Assessment Service we call HIRA. This organization is responsible for reviewing the details of providers' claims and making sure exact payments are made. One more thing I want to mention is that the speed of aging in Korea is the fastest in the world. In this slide, the left hand of each blue bar is the time when the proportion of over 65 years old was 7%, which we usually call aging society. When the proportion reaches 14%, we call aged society, the point where blue bar and black bar meet. In the right end of black bars indicate the time when the proportion expected to reach 21%, which we call super-aged society. As you can see in this slide, for most of the developed countries, it took about 60 or 70 years for the proportion to reach from 7% to 14%. Even in Japan, known as the most aged country in the world, it took about 25 years. But in Korea, it took less than 20 years, and in the near future, Korea is expected to become the oldest country in the world. As all of you know, aging is not just a problem itself. As aging progresses, chronic disease becomes the major disease burden for each country. And effectively managing these chronic diseases becomes a major challenge for the health system. As you can see in this slide, which shows hospital admission due to uncontrolled diabetes among OECD countries, unfortunately, the Korean system doesn't perform well managing this kind of chronic disease. These concerns that Korea is facing, I just mentioned, I believe are not just a problem only in Korea, but in every country in the world. Current health systems in every country were designed almost 100 years ago. At that time, most of the disease burden was acute. The system currently we have was designed to handle this acute disease burden. The current health system is not designed to meet the chronic care needs that we are facing. So, approaches based on the 100 years old model will not be effective, I think. So, we need a new model. We don't know yet what exactly the new model would be like. Let's look at this figure. Conceptually, we have thought medical care as at care in hospital, like inside the red box in this figure. Patients come to the hospital and receive some kind of treatment. We have considered medical care and treatment as almost the same, and everything was done inside the physical boundary of hospital. But when you think about the management of chronic disease like diabetes, we all know that it's not enough to come to the hospital every few months, get some lab tests, and check our health status. Chronic disease should be managed through daily life outside the hospital. To do that, we need to expand the healthcare value chain. We need data from every portion of this value chain, and we need to extend the physical boundaries of the hospital. So let's look at the one project which is related to the data. As Dr. La briefly mentioned in the previous presentation, earlier this year, the Korean government launched an app called My Personal Health Record. Although it is still in a pilot stage, if you go to App Store, you can download and install it. Of course, only the Korean version is available. To understand the information provided by this app, we need to understand the structure of Korean health insurance big data. As I mentioned, all Korean citizens are required to be enrolled in the National Health Insurance Service. When they use clinics, hospitals, or pharmacies, all records will go to HERA database and stored in NHIS database. So, the National Health Insurance Service has all the data for medical history and prescription for all Korean citizens. The My Personal Health Record app uses this data to provide information to users. This is the main screen of the app. On the main screen, if I click the button for the medical records, I can check the records of clinics, hospitals I have visited. I can also check my prescription record. The record, what kind of drug and how much I took, can be checked from the app. The Health Insurance Review Agency also operates a real-time drug utilization review system since 2010. This system operates like this. Let's suppose a patient went to a hospital and was prescribed drug A. When this patient goes to another hospital and the doctor prescribes the same drug A, this system warns the doctor in real time that the same drug was already prescribed. When the doctor prescribes drug B, which has a negative interaction with drug A, this system also informs the doctor about this interaction in real time. Because the computers of doctors are linked to HERA system in real time, this system also gives a warning when the contraindicated drugs are prescribed. Korean people who are enrolled in National Health Insurance can get free medical checkups, including some blood tests, every 2 years as an insurance benefit. So, I can also review this medical checkup data from this app. In addition, this app can be linked to another app like Samsung Health, which measures my daily activities. Through this function, all the information of my daily activities can be sent to my personal health record and can be used with my other medical information. So, with this app, I can always check all my health-related records whenever I want. When I visit the hospital, I can provide my past medical history to the doctor, and I can receive a more accurate diagnosis and treatment. And in the case of an emergency, my health conditions can be shared with the paramedics, and they can provide prompt and proper action. We are talking about health data. When you think about health data, there is another thing we have to consider. As you can see in this figure, the number of people analyzing their genes is increasing rapidly. Perhaps more and more people will do their own gene analysis, and in the near future, I expect most people will store their genetic information on their smartphones. Many experts predict that perhaps in the near future, people will be surrounded by many clouds of data about their health and illness. They even say that when a baby is born, at the very moment, it would be possible to predict what kind of diseases the baby will suffer in his or her lifetime. In the meantime, we have thought that medicine is a kind of a biomedical science, but now we can say that medicine has become a data science. Let's think about this picture. About 5 or 10 years ago, the hospitals and doctors had monopolized the means or devices to produce information about someone's health and disease. Only the hospital could produce health data, and of course, all the information was stored in the hospital. In this situation, because all the information was held in the hospital, hospitals are located in the center and patients stand around the hospital. That's the left side of the picture. But now, as we saw in the previous slide, individuals have the means or devices to produce data on their own health and disease. Many experts say that within 5 or 10 years, the amount of data on individual health will exceed that of a hospital. Now individuals have more information. The structure should change. And now individuals are located in the center and hospitals surround the individual, like right side of the picture. In this situation, the ability to use and to interpret all these kinds of health data should be a very important skill for doctors. I think the fact that many medical schools around the world already include data science in their curriculum is a reflection of this trend. Now, let's look at another project. Korea is known for having one of the best IT infrastructures in the world. About 95% of people have smartphones, and if you stay in Seoul, you can use Wi-Fi in almost every part of the city. Taking advantage of these trends, the Korean government has been working on a smart city project since 2018. This Sejong Smart City project is a project to build a whole new city that can accommodate 20,000 people on a 2.7 million square meter greenfield site located in the central part of Korea. Since the site was greenfield, it was possible to build a completely new city without destroying or removing any existing facilities. Like other smart cities in the world, the Sejong Smart City is based and operated on big data and AI infrastructure. The project contains 7 innovative factors, and one of them is healthcare. When you think about the healthcare in the smart city, we should pay attention to the fact that the concept of healthcare and the concept of the hospital are completely different. There exist, of course, ordinary hospitals that we usually think of, but in smart cities, the city itself serves as an extended hospital with the help of IT infrastructures, big data, and AI. In fact, the Smart City project is still a pilot and ongoing project. We still don't know how this project will be finally implemented, but what is certain is that in many countries around the world, we can see the efforts to expand the boundaries of hospitals. Many efforts are being made around the world to provide healthcare outside the hospital, especially at the home. My lab is also conducting a study to evaluate Korea's home care program. This slide summarizes this kind of a out-of-hospital trend. The y-axis of this figure represents the patient quality of life, and the x-axis represents healthcare cost. When you think about the quality of life of patients, the patients will have a much better quality of life if they stay at home compared to when they are admitted to the hospital. If the patient is admitted to the ICU, for example, their quality of life would be almost unthinkable. So, patients have the motivation to move upward if possible. In the past, due to lack of technology, this has been impossible. But as technology develops, it has become possible to receive care outside of hospitals. The other aspect is the healthcare cost. Every developed country is worried about increasing healthcare costs and the financial sustainability of their health systems. The hospital is the most expensive healthcare space. The government has the motivation to move to left where less money is required if it is possible. As I said, advances in technology are making it possible to give care outside of hospitals. From an individual perspective and from a policy perspective, there is a strong motivation to move healthcare from inside the hospital to the outside of the hospital. This trend will accelerate with the advances in technology. This slide clearly shows the out-of-hospital trend. As you can see in this graph, the number of acute beds in OECD countries is rapidly decreasing. We all know that the demand for healthcare has not decreased. On the contrary, demand for healthcare is increasing due to the population aging or etc. There may be many reasons for this trend, but one of the important reasons is that, as I told with the previous slide, the treatments that were possible only in the hospital in the past are now possible outside the hospital. I believe this phenomenon has important implications for hospitals. In this presentation, I have introduced two pilot projects in Korea and told you about the changing concept of hospitals. Data will become more and more important, and the boundaries of hospitals will gradually disappear. We know that in this world, the speed of change is getting faster and faster. I think it will be really important for all of us to cope with these changes. These are all my presentation. Thank you for your attention.
Thank you, Dr. Lee. Thank you for your nice presentation. The closing time is 4:40, so we have about 50 minutes for discussion. Thank you, three speakers, and now it's time for discussion. If you have any comments or questions, identify yourself briefly and give comments and questions to speakers. And I have one question via online from Jennifer McIntosh. I think this question intended to Dr. Ra, Kuno Ra. Can you say more about how personal data is used within the medical record or within your data analysis or AI systems? This is quite interesting, as many EMRs do not include personal data from smartwatches or other devices. Dr. La, please.
Yes, thank you, Professor So and Dr. McIntosh. Your question about how to integrate the personal live data into EMR is a great question because, as you know, there is a segregation difference between the EMR and then the lifelog data coming from cell phones, smartphones, or the IoT devices. I think even if you can have the data in the EMR, the problem we have as a hospital association is that we have too much data set. I think within the allotted time of our outpatient visits or inpatient care, I think all these data sets coming from lifelog data should be summarized so that I think at the end of the day, the summarized form should be incorporated into EMR rather than the whole set of data. I think so that at Naver in Korea, we're trying to do a pilot study on these, how to integrate our own cloud EMR, outpatient EMR, to all these data sets. Thank you for your question.
Thank you. Thank you, Dr. Ra. Yeah, please.
Dr. Shkyopu, Republic of Moldova. First of all, I would like to thank you for brilliant overview of what is going in Korean healthcare system. So these are extremely valuable insights. Probably audience as myself, we only read what is going on in your healthcare system. And I have two questions to Dr. Ra. Not very specific, mostly to hear your opinion. So first question, in which extent this boost of digital technologies are coming to replace the workforce that is missing all over the world, healthcare workforce? This is the first question. So actually, what is the driver for this development? The lack of workforce or something else? And the second question, what you would expect, what kind of change you would expect in the structure of healthcare force due to the digital technologies in the next 15, 20 years? Thank you.
Yeah, Dr. Lee, please. Dr. La, please.
Yes, thank you. Thank you for our colleague from a beautiful country of Moldova. Yes, I think two questions that you raised is very relevant. The first question was how to integrate the digital technology regarding workforce. I think the human resources question. Is it try to replace the lack of workforce? I think it varies by many countries. Many of us from mostly developed world, like in Europe or East Asia, I think there are limited shortage of physicians, but more on the healthcare allied professionals such as nurses and physical therapists. So that I think at the current time being, it will not replace the workforce. But what I see is that the healthcare personnel are overwhelmed by too much redundant work, very simple work, like asking same questions every single day, doing same old thing for every single patient. So I think that can be managed by procedures called the robotic process automation. So where that you can do repetitive things, with the robotic technologies or the AI technology. So I think you can have your workforce more efficient. So you can spend more time on patient care. So that's the answer for the first question. Second is that what I see in 15 to 20 years in digital healthcare is that I think we've seen in the cases of the AlphaGo 5 years ago by the Google DeepMind. AlphaGo exemplified a very nice example of the AI, artificial intelligence, but it didn't obliterate or eliminate the playing Go, the ancient game of Go. What I'm saying is that it will be an interplay of these technologies into the art of medicine that I call it. The doctor-patient, nurse-patient interaction is an art. I think we should keep this art very well. But anything else, let's say making an appointment to the hospital, having your results received by cell phones, all these things can be done by digital technology. So I think the digital technology within 5 to 15 years will make our art of medicine more art, more humane, human-like patient interaction in the hospitals. I've seen these examples in September in United States, where there's a great financial drive where you can save money, you can be more efficient, then the money can flow into healthcare, and actually the small sectors of the healthcare is being changed. I think these changes will be extended to other parts of the world, like Moldova or Korea. So it will be very exciting. It's too much manual human labor, but I think in the various technology companies, the hospital groups will make these transition very fast. Lastly, we had a discussion at Labor today with our board of directors. We all agree that the healthcare we live in year 2021 today with the COVID situation is very like the dawn of the internet era of 1999, 1998, where the Google, Naver, all these internet companies came into the field. Afterwards, as you know, there is a smartphone explosion, like the YouTube, the Instagrams, Facebook. So everything followed after this Google internet adoption of late 1990s. And I think these great changes now, finally, with the advent and introduction of the AI, large data set computational technologies being available, will change how we practice medicine in more humane way. Thank you.
Thank you. And are there any comments or questions? I'd like to ask Wang Jun Lee. You mentioned about dual track healthcare system in your hospital. You divided your hospital into COVID-19 zone and non-COVID-19 zone. And I wonder if you think the dual track healthcare system will be needed after the pandemic. And if so, how can you handle the human resources such as doctors or nurses? Dr. Wang Jun Lee, please.
Can you hear me?
Yeah, please.
Can you hear me?
Yeah.
Yes. Thank you for your question. And I think that in pandemic era, there should be very separate two spaces between COVID and non-COVID zone. But after pandemic era, that means the post-pandemic, even we need this dual track system as for the infectious control zone and just the general patient caring zone. So I think that we should sustain this dual track system as in the infrastructure. There is not that could be not so difficult burden to the hospital, but the main issue is that how to use the how to maintain the human resources to cover these two areas. And then that could be another challenges after the pandemic, the post-pandemic era. So I think there was a very simple way that how to organize the flexibility of the manpower. And then that means that we operated the CDRT, so contiguous disease response team. That could be always like a responding team for preparing. And also we can reserve the whole workforce to prepare for the infectious disease. So that means that how to make the trained the manpower as for the infectious disease. So anyway, my conclusion is very simple. To prepare the another pandemic or any other new infectious disease, we should train all the manpowers to prepare the emergency situation, and we can operate very flexibly. Thank you.
Thank you, Dr. Lee. And I have a very quick question to Sang-Gyu Lee. Sang-Gyu Lee, are you there?
Yes.
In your presentation, you showed the trend of acute deaths in OECD countries. But unlike other countries, the acute deaths in Korea showed the increasing trend. Is there any reason?
Oh, thank you, Dr. So. I think it's almost time, so I make my answer very briefly. Actually, the data I showed in my presentation does not include the recent data. So when you look at the recent data in Korea, I'm sorry not included in the slide. Korea is also following the country's trend. So the trend is reversed, but why the acute death in Korea was increasing trend? I think the most important reason is that, as I said in my presentation, the universal coverage of national health insurance of Korea started in 1989. So since then, as you can expect, as the economic barrier to medical care had disappeared, so the demand for healthcare has increased continuously for about 20 to 30 years. So I believe that the increasing demand is the main reason for the rapid increase in acute hospital beds in Korea. But as I said earlier, the trend of increasing beds is now entering the same trend as in other countries. So I think we should continue to observe what will happen in the future. Thank you.
Thank you. It's time to close, but if you have any quick question or comments? Okay, no? Oh, thank you for all of you for your participation and all the speakers for your presentation. Thank you very much.